Age Tech Innovators.
Hello, and welcome to the Age Tech Innovators, the podcast where we explore how technology is transforming the way we care for our vulnerable population. I'm Monty, your host, and each week we chat with inspiring leaders who are making a real difference in the lives of vulnerable people, sharing innovations and ideas that help support and uplift those who need it most. Join us as we work together to build a brighter, more caring future for everyone. Now, let's dive in. So, I have the honor of chatting to Peter today. Peter, run me through who you are and what you do in 60 seconds.
Thanks, Monty. Great to be here. I am the founder and CEO of Walkwise, and Walkwise is a remote monitoring company focused on seniors who use mobility aids, which tend to be the most vulnerable folks in our population from a fall risk standpoint, from a medical standpoint, multiple chronic conditions. So, what we do is we just make remote monitoring really simple. And so, we have invented a smart mobility aid attachment that goes on to folks' existing mobility aids. So they don't need to worry about a wearable, about charging, about having a smartphone or having the right app, all these sorts of things that can get in the way for older adults. And really what we're doing is capturing information about what does their day look like? What does their mobility look like? What are their patterns? And then feeding that information in real time to healthcare providers, caregivers, so that they can detect when there's changes, when there's potential emergencies, when there's things that need attention, and just help keep people as independent as possible.
That's so cool. So, when you say an attachment, and I'm great to have you here, but when you say an attachment, can you run us through a little bit more? My mind is, I'm wondering exactly what you mean by an attachment. What are the mobility devices it attaches to, and how does it attach?
Yeah, really what we're focused on are walkers, rollators, wheelchairs, and canes. Those are the most common mobility aids that people use really across the world. Obviously, in different markets, it's going to vary. In the US, there's a lot of rollator walkers because there's quite large spaces and larger homes and assisted living buildings with long hallways. In other markets, they tend to use more canes or aluminum walkers with two wheels. Our standard device is a basically a disc that has two AAA batteries in it. It's a Bluetooth device that attaches to the wheel actually, and it rotates around with the wheel and basically records how many times is it rotating, timestamps every little last detail, stores that data, and then uploads it through our communication nodes that are just plugged into a wall outlet. And these communication nodes are cellular or Bluetooth. So even if you don't have internet in your home or setting up a Wi-Fi device is daunting, you can still use our system even if you don't have a smartphone or any technology in the home. And the benefit of doing the monitoring this way is, as I said before, it makes it as simple as possible for the actual patient. They don't need to do anything once it's on their mobility aid. It just zip ties on to the wheel. It's just there. It has on average 14 months of battery life. So, and that's just on two AAA batteries. And it doesn't have any lights. It doesn't have an on-off button. The patient literally has to do nothing. And that's really important when you're talking about a population that has a lot of things going on. One of those things is cognitive deficits and dementia and Alzheimer's disease. And so if you're asking for any sort of user compliance with a monitoring system, they have to wear this, they have to charge this, they have to keep this device clean, they have to put this on at a certain time of day. That's just really not going to happen. And if you're not getting data, the solution doesn't work. So we've really tried to make it as simple as possible.
So tell us what you do with that data. So you've got a disk which is tracking the distance that people move during the day and when they move. What are you then looking at from that information?
So it goes up into our cloud, and then we are synthesizing the data, analyzing it, making it available for display on our mobile app and our web app. So providers, caregivers can log in, see what's going on. There's a couple of different things that I call low hanging fruit that are really what we're looking at when we're helping our partners better understand how to use the data in their clinical workflows. The first thing you'll notice is with the hour by hour graph where you see the motion kind of grouped by hour, is you get a really good sense of what a patient's day looks like, what their normal routine is. You can clearly see this is when they're getting up to use the bathroom at night. This is when they're waking up for the day and starting their routine. This is when they're preparing a midday meal. This is when they're maybe doing an activity or going outside of the home because the distances are quite lengthy or stretched for a longer period of time. This is when they are going to bed. So you really get a sense of what that looks like, which for a lot of healthcare providers, they really have no idea of any of that, especially for people who are living independently, people in assisted living buildings. That really is not a part of what is being documented or charted because that would just be, frankly, overkill. But the reality is when you understand someone's behavior, you can understand deviations in that behavior. And so if you know, for instance, that someone's baseline is to get up out of bed 2 to 3 times per night, typically to use the bathroom, you would assume, but that's their normal behavior. And suddenly that spikes up to 5, 6 times, your eyebrows raise as someone who knows that one of the signs of urinary tract infections is frequently feeling like you need to urinate. And UTIs are something like the second leading cause of infection that leads to hospitalizations just behind pneumonia. So it's a huge issue for seniors, but no one raises their hand, and picks up the phone and calls their daughter or calls their son or, raises their hand at a morning meal and says, "Hey, I got up to go to the bathroom 7 times." That's just not a part of what we do as humans. But if we know that from the data, we can intervene earlier, we can get things tested, we can provide preventative care, we can keep people out of the hospital. So the first thing that we really look for is, okay, what is someone's normal and what is a change from normal? The second thing we look for is what is their baseline routines that are potentially dangerous? And really the biggest lowest hanging fruit when it comes down to it is mobility aid compliance. People not using the mobility aids as they're intended to. And I really talk a lot about this when it comes to medication compliance because there's so many different solutions out there for making sure that people take the right pills at the right time, which are fabulous. They're fantastic. Everyone should be using those. But we don't have a similar solution to make sure that people are using their walker throughout the day, throughout the night. And there's a reason they've been given a walker. There's a reason that it's reimbursed by insurance, at least in the US. They prevent falls. That's what they do. And they help people stay active. And if they're not being used, they're not going to do any good. And so when you see our data and you see that there's large gaps in mobility aid use during the day, there's large gaps at night where they're having to use the bathroom, right? At least once at night, usually. You start to ask questions and you start to say, okay, well, maybe how can we change this behavior? How can we provide positive incentives for people to use their mobility aids? How do we change the script around these mobility aids a little bit? Because frankly, people don't like using them, right? They make them feel old. They have gone their entire life not using a mobility aid, and now suddenly they're told they need to use one. But they are so good at preventing falls and helping keep people active, keeping them independent, that it's so important that we monitor when they're used and when they are not so that we can do whatever we can to intervene. And that's really where we've seen a lot of our results from our partner organizations that use it as it relates to fall prevention is when it's often just it's not documented anywhere as an issue when people are non-compliant. Unfortunately, the staff in a skilled nursing or assisted living facility will say that's just how they are. They don't want to use it. Imagine someone saying that same thing about a medication. They don't want to take it. That's just how they are. No, if someone wasn't taking their medication, there'd be a huge deal made about it. They'd go back to the physician. They'd figure out, okay, what do we need to do? Maybe we need to change the medication. There'd be all of these interventions put in place. But we don't do the same thing when it comes to basic physical safety. And I'm not saying we need to force people, but there are things you can do that really can make a difference.
Are people aware of the reduction in falls statistically through using mobility aids? Is this something that's well documented and presented to the service users and the families of the service user as much as it is with medication saying if you don't do this, you'll end up in hospital? Do people know about this?
That's a great question. I think some people do and some people don't. I think if you talk to a physical therapist or an occupational therapist, they will absolutely say, well, of course, why else do we prescribe them? Why else do they exist, right? That is fundamentally what they're intended to do. And they're intended to help keep people mobile, which also reduces falls. It's actually an interesting, there's a lot of studies that show that as you are more active, you actually fall less, which would seem counterintuitive because you would think the safest thing to do would just be to lay in bed or sit in a chair all day because if you're not up, you can't fall. The reality is your muscles are weakening as you are not moving around and then you are more prone to falling when you do get up. So a lot of medical professionals do know this. There just really haven't been tools to really measure it, and no one's really focused on it from a technical standpoint. And I think that's part of the problem is you can't manage what you aren't measuring. And up until now, it hasn't been measured.
Mobility adherence and mobility compliance, here it's the word you used. That's the first time I've heard of that. And I've been in the sector for 5 years. And it's so obvious that it is something that people need to be kept on schedule with. So yeah, it's a really, really, really cool product. Run us through, I'm really, really curious about how this came to you. You're the founder and CEO, but the founder aspect, where did you find this idea?
Yeah, it's a roundabout story, but I'll try to keep it short as I can. I did start working on this when I was in undergrad as a mechanical engineering student in Portland, Oregon. And
You can name
really,
drop your uni as well. It's fine.
yeah, University of Portland, go Pilots.
Yeah.
It was my grandparents. I had three grandparents at the time that were using mobility aids, and they were in different settings. One was in an assisted living and had dementia. Another was living in in her home, but with my aunt and uncle in a very near home. And another was living on the family farm and was very independent. And we had different issues with all of these grandmothers. Alzheimer's specifically is we really didn't know what was going on in the assisted living building. And my aunts would call, every day and say, well, is she eating okay? Is she getting down to activities? And the staff would say, oh, well, it's not really our job to tell you every single last thing going on with your mother. But it really mattered to them because we didn't know if she was just sitting around all day, not doing anything, watching TV. And she was such an active woman earlier in her life. And so it mattered to our family to know what was going on, but we knew we couldn't put cameras in her room. That would be an invasion of privacy. And who's going to watch 24 hours a day of camera footage? It just wasn't feasible. And so I got to thinking, well, we're not going to be able to use a wearable. That's not going to get worn. It's not going to get charged. It's not going to stay sanitary. There's going to be all these issues with it. But besides the point that her wrist doesn't move up and down when she uses a walker. So it's not even going to capture the activity. It's not even going to capture the steps. So what can we do to get a sense of when she's moving around that she's not just sitting around all day? So the idea popped into my head. The other grandmother would deal with, as I mentioned, UTIs earlier, constant trips to the hospital, transitions of care that we all knew were extremely poorly managed. She would go from the home to the hospital, then to a skilled nursing facility, assisted living facility, transitional care, all these things. And no one knew what she was capable of doing. No one knew what her routine was at the previous facility. It was generally just unimportant. Every new place she went, they would do an assessment, they would kind of put in their own plan of care, and there was no continuity. And so the data got me thinking about, well, if we had a device that kind of stuck with her as she was moving from facility to facility, from building to building, it couldn't be camera based. It couldn't be, based on the walls or motion sensors or anything like that. It would have to be somewhat with her, but again, a wearable was just not going to be the solution. So this is the only thing that fit the bill. And then the third grandma, she suffered a fall when she was by herself on the family farm. She was 94 years old. She broke her hip Her life alert button was in the other room, and so was her walker. She was not using her walker. And we thought she always used her walker because whenever anyone was there, she would use it. And that's what really got me thinking about mobility aid compliance as a mechanism to prevent falls, is thinking, how did we not know that this was the case? And one thing led to another. Basically, by process of elimination, all the things that I knew wouldn't work with my grandparents, cameras wouldn't work, wearables wouldn't work, motion sensors wouldn't work. So this is the only thing that was left. And that's how it got started.
What a journey. It's really nice to see people applying their engineering skills to solving real life problems that they have in their own space. And it's cool because it's the first time I've heard of this. Nothing about it. It's really, really cool. And really, it's excited to see this grow. I've never heard of this in Europe, but it's such a obvious need. Now we're discussing it today, at least in my
And
mind.
my grandma is still using it. She is turning 99 in about a week, and she is still using Walkwise. She's still moving around, and we're still able to see what she's doing, and it's been fantastic for my family.
Do you have the equivalent of people trying to make 10,000 steps a day? Do you have these mini milestones for people? I just completed a marathon on my walker, that kind of stuff.
It varies so much what people are capable of and what the goals are. What we do goal setting. The caregivers and providers in our system can set goals, and we can send out a message, a text message, a notification on someone's phone if they reach their daily walking goal. Some people are so highly motivated to get activity, and when they started using a mobility aid, their traditional fitness trackers or smartwatches didn't work anymore, and so we provide them with this, and they're so happy to have that tracking ability back where they can see how much they're moving, because people take such pride in it. And it's so, mobility is such a strong correlation to quality of life. It is really, from an objective standpoint, the number one indicator of quality of life that you can have. If you are moving around, engaging with your surroundings, getting outside your house when possible, getting outside your room when possible, your quality of life is going to be so much higher. And this is one way to help people maintain that.
It's awesome. I'm imagining a Strava app, but for grannies who can start to compare the different leaderboards.
One thing we like to do is we like to group people together. So we don't necessarily want to say, well, Monty walked this much this month from a public standpoint, simply from a data privacy standpoint. But what we can do is we can say collectively as a group, everyone at this building with this healthcare provider collectively walked the length of the state of California, for example. And
That's
that's a
so
really fun
good.
thing to do because it is a collective thing and everyone's contributing to that. So it's really fun.
That's really beautiful because the gamification of being younger, how can I improve my sleep? How can I improve this number that I'm tracking? Is such a good way of optimizing. And I feel like, as you said, or as you've seen, there's no gamification or real metrics that can be tracked as you get older. Yeah, I guess you could track the pills that you took on time. It's not that much fun.
Right.
There's nothing attached. Yeah,
That's a good point. And it's so interesting the gamut of people who use mobility aids because you have people who are in their 60s and 70s and are dealing with potentially a disability and they're very much into gamification. And then you have people in their 80s and 90s who are perhaps dealing with dementia and couldn't care less about anything with that. But it's so important for the caregivers because there's no way that they can get reliable, objective information from the patients themselves because of the cognitive deficit. So it really is interesting the gamut of people that we're able to serve with this.
so you came up with the idea, you did some initial prototypes. What were some of the challenges that you had to overcome in terms of market penetration
Mm,
with this
yeah,
product? How do you distribute this? I'm sure our listeners, definitely some of our listeners right now, have products in a supportive space, not a competitive space, a supportive space that are thinking, wow, Peter's gone and done it. I would love to hear some of his perspectives on what he's learned.
it's been a huge challenge to be perfectly honest. And that's what, I spend the majority of my time working on now is thinking and going to different markets, going to different conferences, having really, frankly, difficult conversations with people because everyone agrees that this is a fantastic idea. And I think a lot of senior technology people are in conceptual agreement with. They say, oh, it'd be great if we can monitor this. Like, oh, this is so useful. But at the end of the day, senior care is a business. And when it comes down to dollars and cents, that's really where the rubber hits the road. Not to use too many different turns of phrase, but so originally, as you can imagine from my founder story, I originally conceptualized this as a direct consumer product. I thought, well, will be basically right alongside Life Alert and some of these other, personal emergency response system would be the industry phrase, a PERS device, and this would be right alongside that, right? Families like myself would want to get this to know what's going on with their loved ones, see if get notified if there's a long period of inactivity, get notified if the mobility aid tips over, all these different things. And it worked a little bit, but unfortunately what we found, and I think anyone who's in this business will kind of resonate with this, is that families are complicated and they don't necessarily want to be full-time caregivers for their loved ones, even if that's in a remote capacity, right? And that's why we have in a lot of countries such a large senior care industry, is that you can basically offload that responsibility to other people and to institutions if you have enough money. And so a lot of what we found is that well-meaning people who loved their adults or loved their parents, loved their grandparents, were frankly uninterested in the data on a daily basis. They like the concept of it, but when it comes down to, well, who's actually looking at the data, who's actually intervening, that became very challenging very quickly. And what we realize is that a lot of the interventions that need to happen as a result of the data are actually medical interventions. And so when we transitioned to more of a B2B model, where we were working with provider groups or working with physical therapy groups, working with senior care facilities, we understood that there was a lot more that the data could be used for if it was in the hands of the right people. I talked about the UTI example, but we've had instances where mobility decline was a instance of acute congestive heart failure, or a excess increase in nighttime activity was the sign of a mental health episode, an instance of someone stopping taking their sleeping pills. And these are all things that really require a trained medical professional to, first of all, understand what's going on, and second of all, to intervene, because not all families understand the signs and symptoms of some of these things. So when we transitioned to that model and said, well, let's use it to work with organizations to help take better care of people, that's where we really entered two main markets. So we have our value-based care model, which is for organizations that are fully capitated or have a value-based care payment model where they really are incentivized to keep people healthy. They're incentivized to prevent hospitalizations. And that's where we get a lot of our data around fall prevention, because it is such a costly thing for them. And so when you can reduce falls by 20, 30, 40%, as we've shown with some of our partners, that is saving them a lot of money. And so that's how the economics of it work out.
You mentioned the value-based model. Can you just explain that a tiny bit more about, because I understand, from what I understand, would these be providers who look after individuals when they've been discharged from hospital, and their whole incentive from the insurer is to keep people at home safe for as long as possible? Can you just run me through and expand that slightly?
Yeah, that would be an example of a value-based care payment arrangement, right? Where the insurer is issuing a bundled payment for a patient after, say, a hip surgery. And so the provider, after their discharge from the hospital, has a 30 or 90-day window in which, if they are readmitted to the hospital because of a fall, right, because they're not using their mobility aid or because they pick up an infection that isn't detected early enough, then they're on the hook for a lot of that second hospitalization. And so they want to avoid that. Another example would be like a fully integrated payer provider system where the provider is the payer, where they are incentivized from every angle to try to reduce high cost episodes. And that's where we really like to work, because everyone's kind of aligned on, we want to keep people in home. We don't want them to end up in the skilled nursing facility because that's really expensive on a daily basis. And so what can we do to help them preserve their independence? Let's get them the mobility aids they need. Let's make sure they're using the mobility aids they need, and let's try to get on top of health issues sooner. So that would be the value-based care side of things.
And so when the provider is the payer, that means this just I'm breaking it down because it's definitely some of our listeners are always trying to think about how they can get to the US, and some of these more specifics about this actual entrance they find a little bit murky sometimes. It puts people off entering to the US because they're like, oh, I don't understand the healthcare system.
So murky.
So when the provider is the payer, that's, for example, I'm a company that supplies some support, and then I pay for the support for the vulnerable individual, and then I'm reimbursed. Is it Medicare, Medicaid? That's who's actually paying me as the provider
Yeah.
is the payer.
Yeah, typically what it looks like is you'll get a flat rate from the government, at least when we're talking about the older adult population, because once you turn 65 in the US, you're eligible for Medicare, and then there's all these different things that go along with that. But what we're typically talking about is a hospital system, a provider network, having a population of patients in which they get a flat rate for that population to care for all of their health needs from the government. And so what they get the same amount of money regardless of how much money they spend. Now they have to maintain certain quality standards. Of course, if their quality goes downhill, they're going to get penalized. But at the end of the day, what they're trying to do is reduce the amount of money that they're spending, and that those are things like accountable care organizations that was created as a part of the Affordable Care Act, that happened under the Obama administration. And so there's all these different sorts of arrangements, and then you can have variations of that where you have private payers, these big insurance companies that have contracts with provider networks that say, well, if you improve this quality score by X percent, which helps us save money as the insurer, we'll provide you a bonus or an incentive to do that. So you have all these different things. At the end of the day, the incentive is almost always on the value-based care side to spend less money while keeping quality high. And really, the main way to do that is preventing hospital admissions, preventing skilled nursing utilization. The other side of that is the traditional fee for service, and that is 50% of the I'm estimating, but it's about 50% of the healthcare industry right now. And that is just simply your doctor, your therapist, you provide a service, you get paid a certain amount of money for that service by either the government through Medicare or through a private insurer that someone has a Medicare Advantage plan. So it's been privatized. And that is really where we are growing right now because there are new reimbursement codes that the government's come out with that said, actually, we want to promote remote monitoring in a variety of different ways. Specifically with us, it's remote therapeutic monitoring, more so related to therapists and people who have mobility issues. But there's all sorts of remote monitoring systems that exist. I mean, the government's paying for remote monitoring of blood pressure or weight or pulse ox or home exercise programs, things like this that really help extend healthcare outside of the four walls of the clinic, outside of the four walls of the hospital, and make it possible to really kind of take part in the digital revolution, right, in healthcare. So the government actually wants this to happen and they're reimbursing for it, which is great.
Is the government reimbursing for monitoring mobility in seniors yet?
Yes, and that's what we're able to make use of with the remote therapeutic monitoring code. So a physician or a physical or occupational therapist can use Walkwise as a part of their plan of care and get reimbursed not only for the device, but also for the time that they are spending reviewing the data, having the data influence the plan of care, having a conversation with the patient about their mobility. So all those things I talked about earlier around, how do we incentivize mobility aid compliance? How do we, prevent illnesses early? The government and by extension, the private insurers are reimbursing for the time spent doing that, which has been a fantastic change over the last 4 or 5 years, really kind of spurred on by COVID, thinking about, okay, well, we know healthcare can't just happen in the clinic. How do we make it more of a 24/7 thing? How do we make it more longitudinal? And has really resulted in this whole new part of the healthcare economy, at least in the US, that is focused on remote monitoring.
That is fascinating. Peter, you're right. We could chat about these specifics for a long time, but I want to ask you a couple more questions and change direction just slightly, not because I want to, but because I know that some of our listeners are curious in some of your other perspectives. So imagine if we fast forwarded time 70 years and you wake up in the morning and you look in the mirror and suddenly you're an elderly man, maybe 80 years, and you've got grey beard, you've got wrinkles under your eyes and on your forehead, and you go, wow, I'm an elderly man. What technology would you like to use, and what would you like your day to be like in terms of the technology that supports you when you're an elderly man?
Well, that's a great question. First of all, life expectancy in the US is actually going down. So I don't know that I have another 80 years. We'll see. At the end of the day, it all comes down to quality of life, doesn't it? I mean, that's what people want is they want to be independent. They don't want to have to rely on other people. They don't want to feel like a burden, and they want to do the things that they enjoy and spend time with the people that they spend enjoying time with. So I think the technologies that I would want to support me would be, first of all, mobility, right? I mean, there's such a huge, I mean, health discrepancies between people who have access to transportation and people who don't have access to transportation, right? And at least in the US, there's a lot of momentum to start actually paying for transportation services to getting to medical appointments and getting to other sorts of things. So, I mean, anything that makes mobility easier, innovations in mobility aids, who knows, innovations in exoskeletons, but even just like things like Uber and Lyft have been game changers for people trying to access the world despite having, mobility limitations. So, I mean, continued innovations in that space would be fantastic. I know the VR bubble has burst a little bit. Ever since the whole GPT came out, and now we're all focused on AI. But I still think that there's a lot of opportunity with VR to provide experiences to people who are maybe not able to do all the things that they were able to do in the past. We were talking before the podcast, Monty, about me wanting to visit London, having never visited London, and being such an admirer of the culture. And I think if I was 90, it wouldn't maybe be practical to visit London, but could I have a similar experience, and that would be enriching in a way and enrich quality of life. So I'm bullish on VR specifically for the elderly population. I don't necessarily know if it's going to replace in-person experiences for maybe people who are more mobile, but I think there's a lot of low-hanging fruit there still.
Amazing. So we've got exoskeletons, mobility support, and
I mean, admittedly, exoskeletons would completely destroy my business, but that's the what I joke about is, how long have walkers and wheelchairs been around? I mean, hundreds of years, right? And I am skeptical that we're going to get to a place in the meaningful future, that the foreseeable future, where everyone has exoskeletons and can afford exoskeletons and all these things. So I think walkers and wheelchairs are just going to be around for a very, very, very long time, and we need to do what we can to support people. And one of the amazing pieces of legislation that the US has that not many other countries have is the Americans with Disabilities Act, which basically mandates building codes and, among other things, to be accessible for people with mobility aids and mobility restrictions, wheelchairs, these sorts of things. And so the US is actually extremely wheelchair friendly compared to other countries. And so I think that there's a lot of work to be done there to maybe make wheelchairs a little bit better at traversing different environments, but there's also some policy things that can happen that really do make a difference in people's lives.
that's really, yeah, I think you've got nothing to worry about, at least for the next 20 years, personally.
One would hope.
Yeah.
One
And
would
so
hope.
my last question, and it's especially apt because you are a founder, and founders tend to understand this experience bec- more than most because they're closest to the fire pit. What advice would you give to aspiring innovators and people looking to enter the space? What would you say to them to encourage them?
Yeah. I usually always start with some discouragement, honestly, because this is not for everyone. It really isn't. It is such a hard thing to do. And I'm not saying that in a way that makes me and other founders seem like a martyr, but it is difficult. And there's usually not very much money in it. And most people fail, and most people, I mean, it can really take a stress on mental health. And so some people, I don't want to say aren't cut out for it, but maybe they just have better options, right? Or things that they things ways that they can make a difference in the world. That being a founder is not the only way to make a difference. I mean, too often it's glorified, right, as the way to make the most difference in the world, but that is absolutely not the case. So it really isn't for everyone. And I would say if you are interested in doing it, you have to have a great support system around you. I would not be able to do what I've done without the assistance of my wife, without the assistance of my family, just from a support standpoint, knowing that I'm not going to be out on the street, if my company goes bankrupt in those early days. And then I would say, and everyone knows this, but you have to be absolutely passionate about what you're doing. The going get tough so often, where if you are not doing it for the right reasons, you're not doing it because you love it, you will quit or you will hate what you are doing, and it will take a negative toll on your mental health. So I would really encourage anyone who is interested in doing it to actually, first of all, work at a startup, because then you'll kind of see how the sausage gets made without doing, jumping full in yourself. Monty, you and I did not have the luxury of doing that because we started what we were doing in undergrad. We came into it blind, not really knowing, not having worked at startups. But I mean, that would be my first advice, right? Is like dip your toe in before you jump all the way in. See if you like the uncertainty of it. Some people can't handle the uncertainty of it. See if you like the crazy amount of work, but see if you also like the amount of different things that you get to do as a founder, right? You're wearing all those different hats, which is part of what I love.
There'll be a certain select few people who are listening to this and hearing this discouragement as a challenge. As
yeah, they might. Yeah, they might, but I think you just have to be honest with yourself. So I was taking the Intro to Entrepreneurs class at MIT when I was there, and this big class with lots of people, and they bring in these exceptional founders to be guest speakers. And one of the speakers in the very first week said, if you are in this class, you need to go home right now, talk to your significant other if you have one, talk to your family, talk to your friends, and tell them that you are in this class and you are actually considering being a startup founder, and have that hard conversation about what that will look like if you get the bug and you find an idea and start with, because there are so many people whose, frankly, their marriages fall apart because they're not on the same page about what that looks like and about all the time that it will take and about all the monetary resources that it will take. And if you don't have an honest conversation with the people around you, even if you're just thinking about it, you're probably not ready, right, to take that leap. So have those honest conversations as early as you possibly can.
Peter, it's been such a pleasure to have heard your perspectives, heard your story, and I can't wait to see where Walkwise takes itself in the future and where you continue to drive innovations and bring your engineering skills into solving real life problems. So thank you for your time. I really appreciate it, and catch up with you soon.
It's been a pleasure. Thank you.